So since we have been speaking about how to do MIGS, I thought it's good to take 10 minutes to discuss why we should be doing MIGS, for which patients, when, and if there is any purpose at all in doing MIGS. And we are just going through some of the good literature that we have up till now. There is a lot of literature coming up every year. If you see, there are so many articles on MIGS. We are going to look at some important ones. So this is the first pivotal randomized controlled trial on the first generation iStent, the 2-year results. And they reported, when compared to cataract surgery with iStent versus cataract surgery alone, there was a significant difference in the success outcomes, where success was defined as an IOP reduction of more than 20%. And they also found that the IOP as such, between the two groups, there was a significant reduction. Now, we had some discussions about CyPass and corneal endothelium. What about iStent and corneal endothelium? So this is a long-term endothelial safety profile with iStent inject in patients with open-angle glaucoma. This was an extended follow-up of the pivotal trial for iStent inject, of which 227 of the initial randomized patients were followed up over a long time. And they found that there was no significant difference in the mean endothelial cell density between the cataract group and the cataract surgery with iStent group. And this is a study which randomized patient to 1, 2, and 3 iStents each. And when the outcomes were compared, it was found that the use of 2 or 3 iStents had a better outcome when compared to a single iStent alone. So the presence of 2 or 3 iStents, the success rates were much higher when compared to a single iStent. And what about Hydrus versus iStent? Both Hydrus and 2 iStents were found to be equally effective in reducing the intraocular pressure, but Hydrus implantation had a slight advantage over a single iStent in this meta-analysis. Now coming to the Cahoog dual blade, we have already seen how the technique is. And the initial randomized study, which compared Cahoog dual blade with phaco versus phaco, actually, though they found a difference in the IOP control as well as the number of anti-glaucoma medications, this difference was not found to be statistically significant. But after this, there have been many retrospective studies, and this meta-analysis, which took data from 26 studies and 1,659 patients, concluded that KDB with phaco had a superior IOP reduction of about 22.74%. Even then, it is modest. It may be good for mild to moderate glaucomas, whereas phaco alone, the IOP reduction was much less. Now coming to Teneto microhook, Lopamudra has already covered many of these studies. So this is the study by Masaki Teneto himself, in which he found an IOP reduction. The mean IOP reduction expected was 31%. And as we have already seen, Teneto microhook addresses a larger area of the trabecular meshwork. So it could logically bring about a superior reduction. It is possible. And this was his study. And he also compared outcomes of suture gap versus Teneto microhook and found superior outcomes with Teneto microhook. This IOP reduction as well as the number of reduction in anti-glaucoma medications in this study was superior with Teneto microhook. And we also have the study from Arvindai Hospital, Tirunelveli, where they found a mean IOP reduction of 51% with Teneto microhook with cataract surgery as opposed to cataract surgery alone. And the few studies that we have where toric IOLs have been combined with minimally invasive glaucoma surgeries are with Teneto microhook, and they found good outcomes similar to cataract surgery alone when toric IOLs were combined with Teneto microhook trabeculotomy. As far as BANG is concerned, there is very limited literature. This is one retrospective study of BANG where they found about 20% reduction with cataract surgery, when BANG is combined with cataract surgery in about 70% of the patients. And this randomized control trial, which compared BANG with suture GAT, they found that BANG was definitely inferior to suture GAT in terms of IOP control, complete and qualified success, as well as a reduction in anti-glaucoma medications. Coming to gonioscopy assisted transluminal trabeculotomy, this is the 4-year surgical outcomes of GAT in a significant large number of patients, and what they found was the cumulative failure rate at 4 years with suture GAT was 53.9%, And what is a little more concerning is the cumulative reoperation rate was 42%. So how does this fare when compared to trabeculectomy? So if you look at the primary tube versus trab study, at the end of 5 years, the cumulative probability of failure was 35%. So compared to trabeculectomy, probably GAT did a little worse, but then there is an advantage that the superior conjunctiva was preserved in these patients for a future surgery. Now comparing 360-degree, 180-degree superior or 180-degree inferior GAT, the outcomes were similar. There was no added benefit of 360-degree GAT when compared to 180-degree GAT. This was a randomized controlled trial with a 1-year follow-up. And as expected, the rate of high FEMAs were significantly less in 180-degree GAT when compared to 360-degree GAT, and the IOP spikes were also much less. Now, what is the role of minimally invasive glaucoma surgery in primary angle closure glaucoma? I don't think we still really know. So, though goniosynovial does not really come under the purview of minimally invasive glaucoma surgery, a lot of research has been done on GSL. And this meta-analysis concluded that GSL does not give additional benefit in primary angle closure glaucoma. So there is no additional benefit in combining it with a cataract surgery. So this is the only randomized controlled trial of GAT in primary angle closure glaucoma. And they found similar outcomes with phaco-GAT as well as phacos. And the success rate of phaco-GAT was 94.5% when compared to phaco, which was 86.8% of complete success, and this difference was statistically significant. The outcomes were superior with phaco-GAT when compared to phaco-emulsification. And high FEMA and FM were the common complications in phaco-GAT. And this delayed visual rehabilitation with phaco-GAT did not affect the final visual outcome. So phaco-GAT was found to be more beneficial than phaco-emulsification alone. So as far as MIGS in PACG goes, the available evidence suggests that cataract surgery in combination with MIGS can be safely and effectively performed, but these are largely based on retrospective studies and small RCTs. Now the big question of all, TRAB versus GAT, should we be stopping doing trabeculectomy at all? There is not much literature on this if you look at the good quality studies. This is a single center retrospective comparative cohort study which compared standalone GAT versus standalone TRAB, and they defined success as an IOP reduction which is much more significant, that is at least a 30% IOP reduction, and they found that complete and qualified success. With TRAB, the complete success was 59% and with GAT 46%. Re-intervention was higher in GAT as compared to TRAB. So what this study concluded was that at 18 months, GAT was as effective as TRAB in reducing intraocular pressure. This is over a 1.5 year follow-up. And TRAB, of course, provides a greater IOP reduction than GAT, but ab interno trabeculotomy is less invasive and spares the superior conjunctiva. In juvenile glaucoma and congenital glaucoma, there is not much of consensus. GAT is known to do fairly well in juvenile glaucoma, but Cahoog dual blade goniotomy not so much. Whereas in congenital glaucoma, both Cahoog dual blade goniotomy as well as GAT have been shown to have good outcomes. So normal tension glaucoma, there is no definite advantage of combining a minimally invasive glaucoma surgery with cataract surgery. Cataract surgery alone does well. And as far as secondary glaucomas like silicone oil induced glaucomas go, there are very few studies and just a few case series to know the outcomes. I will end up with this meta-analysis which compared combined microinvasive glaucoma surgery with phacoemulsification. So this study divided the minimally invasive glaucoma surgery into 3 groups. One is the trabecular meshwork bypass devices like iStent. 2 were non-GAT goniotomies that remove the trabecular meshwork, and the third group was GAT, either done with a catheter or with a suture. And the IOP reduction was the best with GAT, which is about 9.35 millimeters of mercury, as opposed to 3 to 5 millimeters of mercury with devices or the other ways of doing minimally invasive glaucoma surgery, like Neethu or Cahoog dual blade. And all MIGS groups had equal or lower rates of sight-threatening events and secondary glaucoma surgery when compared to control. GAT had the highest incidence of 5 FEMAs. So based on this study concluded that based on the current peer-reviewed articles, there is strong evidence that when compared to phacoemulsification alone, combined phacoemulsification with MIGS is beneficial for patients with open angle glaucoma and does not increase the incidence of vision threatening events.